Welcome to Healthcare Quality and Risk Matters, the show where we dive into the topics that matter most in healthcare quality and risk management. Wondering about patient safety, quality improvement, or risk mitigation, but weren't sure who to ask or were afraid to ask? Well, you're in the right place. We create a safe and judgment-free space to explore these critical topics together that will leave you informed and inspired to make a positive impact on healthcare and patient outcomes. So let's learn and grow together because healthcare matters.
Well, good afternoon. You have reached the November edition of Healthcare Quality and Risk Managers, and thank you for joining us this afternoon. I am joined by my panel. We have with us the Chief Operating Officer of Aperitisoft Healthcare, Rob Santamoor. He is our registered nurse, but also the expert of everything risk and quality when it comes to healthcare. And Dr. Timothy Brown, who is our expert with anything to do with the administration of hospitals. And he also leads our customer success team. And I'm Gary Bierc, so I'm the CEO of Aperitisoft Healthcare. We're so glad that you are joining us again today. We have a special guest today. She is the Executive Director of Bayshore Assisted Living, but she has an incredible background. Not only is she an MBA and a certified internal auditor, she has a background in statistics and math and had an incredible career with Ford Motor Company. I'd like everyone to welcome Monica Dowling with us today. And because we have a guest today, everybody, we're going to have a little bit different format. We're going to go a little longer. We're going to go 45 minutes today rather than just a half hour. That way we can give our audience plenty of time to ask questions to Monica. But also we can get a chance to put Monica on the hot seat and we're going to hit her with lots of interesting questions. The reason why it's special this month is that Monica is actually a user of Aperitisoft Healthcare. We're not here just to pitch Aperitisoft Healthcare, but what it means to have systems like ours in a healthcare facility. We got a couple rules we'll go over. Monica, we'll let you answer questions as long as you can. Although if it goes too long, I may interrupt you. Rob and Timothy, with your color commentary, we're going to have to keep it to our 1 minute rule. Okay.
I will try.
Okay.
We'll do our best.
Keep that going. So with that, again, welcome, Monica. And Timothy, I'm going to let you have the first question for Monica.
Well, absolutely. Appreciate it, Gary. And Monica, thank you for joining us. I know November is Long-Term Care Awareness Month, so this is a great time to really talk about different topics that are really focused around the overall long-term care industry. And my first question to you, Monica, is no stranger, but what specific challenges or patterns of incidences have you seen in your facility that may have potentially prompted you to make decisions to implement a new quality management system?
Ooh, why did you do it, Monica?
Well, I did it to try to help us prioritize which areas we had incidents in. We just due to the sheer number of incidents we had, I was trying to figure out how I could group them and how I could come up with good corrective action plans in order to address them in an efficient manner, and so that they did not occur again in the future.
I love that.
Yeah.
With adopting, there's a quality management software to improve patient care and patient outcomes. Have you seen a change in your organization? Would you give advice to other people in your role across the country to adopt platforms like this?
Yes. Well, it helped us with the system to really look at and document the incidents and then be able to group them. And we were able to group them the bulk of them in 3 categories. They were either fall related, they were skin integrity, skin tears, or bed sore related, which is a common problem in both hospitals and in long-term care. And the third category was probably medication errors. Those were kind of 3 large groupings I had of incidents. So what we did is we looked at and brainstormed with the team, what type of things could we do in order to reduce each of these areas. And for example, falls, we just put in place a number of actions and decided who was going to lead them, and then had in our shift change meeting room, we have a board there for like critical reminders of things to do that came from these corrective action plans. So some things we did for falls was looking at for the residents in the facility, what type of restraints or equipment or other things we could do or alerts we could do. So we ended up evaluating by resident bed rails, half or full bed rails, depending on circumstance, alarms, bed alarms, body like screamer alarms if the person gets up, mats on the floor. A lot of the falls were unwitnessed falls at night. That was one of my big areas. The other was where they would just surprise us during the day and get up out of the wheelchair and get around. So using those type of devices and also call buttons. A lot of our residents have dementia, so call buttons would not be used by them so readily for a lot of them. But using all these other devices, actually on falls, we've had about a 77% reduction in falls.
Wow.
That's amazing. Wow.
So
That is a massive reduction.
It's been a very concerted effort on that area.
I've supported I'm so sorry to interrupt. I've supported hospitals with fall reduction programs. There's using some not great platforms and not having as engaged leaders as yourself. We weren't able to move the mark even a handful of a percent, right? So you and your team protecting your patients, there's at a 77% higher rate. Awesome. Like, shout out to you all. Like, what a great place.
It went through iterations, though. So sometimes it's one thing is putting a change in an improved process. The other is ensuring we're following the process, right? So after we put in place the process improvements and got agreement with the doctor or the physical therapist who also supported these type of restraints for that particular resident, we also found out, sometimes we forgot, they didn't put them up before bedtime or whatever. That's when we re-emphasized an alert board in the shift change meeting room that we go over before shift change, making sure whoever's in the lead role is the one responsible to make sure and double check that these security improvements are in place for those residents, just to double check that when they went to bed that they actually had these 3 or 4 things that resident's supposed to have per their care plan in place. In the state of Florida, they've gone through cycles on having restraints, and we used to have restraints, then it was pretty much all taken away. Then we had a signature campaign that went through with the Agency for Healthcare Administration, and I was one amongst those who signed that and thought, well, we need to have some process because people are just falling left and right. A lot of our residents can walk 5 steps and they're going to be on the ground. But it requires, now we have a doctor's order. It requires that we have consent from either the person or their medical surrogate. And then it also requires that it's in their care plan. So you can't just willy-nilly do all these things, but you can make a concerted effort to review with the doctor and also include a physical therapist if that person has a PT person assigned to determine what is prudent for that individual to take as far as additional safety measures. So it is a process, but if you actually go through that, you can make a big improvement.
So Monica, you were doing things manually before, correct? Meaning that it was clipboards and Excel spreadsheets and things of that nature. And then you moved to having an automated system. Did the automated system do a couple things for you? One, did it make it easier for your staff to report incidents? And then second, once those incidents are reported, did it make it easier for you to investigate and then ultimately take corrective action?
Yes. So yes to both. The first question is if we actually had about 150% increase in our reporting of incidents.
Well, that's wonderful.
Amazing.
That's good.
Talk about a line of sight.
It's very simple to go in. It's very user-friendly, the system, which not all systems are. Very intuitive, and it walks you through what you need to fill in. I mean, there's minimal training involved to get started on this. So whoever's on the floor who witnessed the issue can log it in as an incident. And then it'll get documented and tracked. And then the system does force you to actually put in place, corrective action plans for what are you going to do to address this issue, and so that it's not a broader issue for the facility and it doesn't happen again. It gives you line of sight to where your issues are. And it also lets you take a bird's eye view from a management standpoint to understand where your risks are and what's going on to address them. So on the corrective action plan side, you get an owner for the overall plan, but you can also have owners for individual milestones underneath, and they will get email reminders. All right, so that was helpful. They get email reminders of the timing of when they had committed to get their milestone done. So you can see where we're at with subsets of an overall corrective action plan for an item. And if you take a bird's eye view from an overall facility, or say you're a CEO of a long-term care chain of facilities, you can get an understanding from a business unit or location, as well as from a function or department standpoint, how your organization is doing from a risk standpoint, compliance standpoint, and how you're, and also on your corrective action plans, how you're doing.
What does all of this mean for your staff? So, like, speaking about falls specifically, does that change anything about how your staff feel and what that means for staffing? Like, what are the downstream effects of improving quality?
So when you look at how we approach this, we address the things that were causing us the most grief, right? The biggest bang for the buck, right?
Low-hanging fruit. The low-hanging fruit.
We address the falls. We address the skin tears, the bed sore issues, the medication issues. And by addressing some of these larger issues, we don't have as many crises, right? So the number of surprises and crises of people falling out of bed, falling out of their wheelchairs, having sores, having to send them out, reduce stress significantly, both during the day and at night. And I was typically the one who would get the calls at night, where I'm called every time. If somebody needs to go to the hospital, I ask to be called. I want to know before, when we're going to send somebody out, what's going on. So I can sleep a lot better at night, which is a wonderful thing. I used to get, calls pretty much every week during the night. And, that's a big deal, both for myself and for staff. The stress level goes down significantly, which helps a lot as far as managing the facility, reduces burnout among staff, increases the morale among staff when you can have more time with the residents and less time with crises. It also significantly reduces risk from a legal standpoint. You don't have the same amount of risk as you did if you had a lot more falls. Falls are a big reason for head injuries, unwitnessed falls, things that happen, right? We don't watch people 24/7, but, we always have a risk when somebody falls and so forth. Could you have done more? It helps from a revenue standpoint, because often families ask, well, what do when they come for a tour or what's going on, they're often coming because they're not happy with where they have their family member placed today. And often it's because of the lack of care or the number of falls or number of issues they've had. So to be able to talk about, here are things we can do to improve the safety for your family member, so that they don't just have all this additional trauma to deal, in addition to dealing with whatever, cancer or dementia or whatever, have all these additional things happening to them. just trying to be proactive from a safety standpoint makes it a much happier, manageable facility.
Absolutely.
You know, what's interesting in this, this is just a comment. I think, Timothy, you've got a question you're about ready to ask. You being a long-term care facility and an independent facility, you're almost able to see a little bit more closely where maybe in a hospital you cannot, just how important it is to connect the dots between quality, risk, and strategic goals and revenue and having a business that's successful. And, we've talked about this many a time, guys, at our podcast, that, often CEOs don't make that hard line connection, that, if they do not take this stuff seriously, they're never really going to grow to whatever their aspirations may be.
All right.
Because things are always.
That's what I'm saying. Yeah, a lot of the stress, a lot of the burnout comes from dealing with crises all the time, crises after crises all day long. From when you get in the door. I
wonder if there are hospitals out there that are struggling with their leapfrog scores or with their DNS scores, and they feel that way. They feel that stress that they go to work and it's like crisis upon crisis they have to deal with, and they're not connecting the dots. That it is a system of quality that needs to be improved.
And it puts you in a much better position when you do have the audits come in. In the state of Florida, we have biannual licensing renewals, but then you also get complaints potentially from families, whether it's to the Agency for Healthcare Administration, ACA, with the state, or if it's the ombudsman coming in, or the health department coming in, or number of different agencies coming in, no matter whether you're a hospital or you're a long-term care facility. And having a good program for managing risk and quality compliance, it makes a big difference to be much more prepared and have everything documented when you're then going to sit for an audit, because it will happen. It's just you don't know. They just, in Florida anyway, they just randomly show up, right? They'll show up at your door at 8:30.
Everywhere.
Yeah, true.
Timothy, before you dive into your question a little bit for our audience, please tell us where you're from out there. Go ahead and go into the chat and tell us where you're hailing from today. And go ahead and start putting those questions in. We'll try to field them as we can. We're going to leave the last 15 minutes specifically for you guys. But, if you have some great questions or comments now, we'll try to weave them into our conversation. Okay.
All right. I'll jump in. Thanks, Monica. This has been great so far. I want to know, from your standpoint of a leader, and you're trying to get your staff involved in this new decision of moving to a quality management system from what they're pretty much used to and comfortable with. We know a new system is really only as effective as its users. How did you approach staff training and ensuring ongoing engagement with the quality management system that you guys have implemented?
Great question.
Okay. Well, initially we talked about really looking at just trying to get an understanding, as I said, prioritize where our issues were, and trying to have a tool, a system to help us facilitate that, with the goal of down the road, this is going to help us to improve the safety of our residents, the safety and well-being of our residents. And that was really how I pitched it initially. It's here to help the residents, right? And it's a journey. It doesn't happen overnight, but everybody went through a round of training, initial training, and then we had one of our RNs, who's our risk and compliance officer, as the lead person to go to, help with questions, answers, any issues you have as far as getting things loaded. You really need to have one person who's going to be your implementation lead. Who do they go to, right? So you have a go-to person to really push this, because otherwise it'll be a little bit all over there, right? You really need to have a go-to person, so when they're having trouble and can't get it in, sometimes initially we had people put it on the sheet and then they got assistance to load it later, so they knew how to do it. But it's training them, and then letting them see, well, actually suggestions and brainstorming ideas that come up are actually put into live use, right? We're actually doing implementing these ideas and putting people responsible for handling the implementation. May not be them. They brought up the idea or so forth, but maybe a different department or whatever who's responsible to implement it.
Was it hard? And I don't mean to simplify the question so much from there's my standpoint, but there's, as a risk and compliance quality leader, there's the idea of implementing something like this. Honestly, it sounds like it could be really hard. Do you feel like it was hard for your organization to implement something that's made such a clearly profound improvement in your quality?
I think because the system is pretty intuitive, and you walk through the screens, it walks you through what you need to input when you're doing incident management. At this point, we've only initially launched that module of what all is available, right? There's a lot more available in Aperitisoft Healthcare than what we have done so far. So you have to start somewhere. So you have to pick, well, what area do you start? We started with incident management, and then we'll work to expand from there. Incident management, and then we went to CAPA management because that was a natural flow to manage your corrective action plans to fix and reduce the incidents.
And they're integrated. They're
right, the integration of the system, and the fact that it's so intuitive and user friendly. It doesn't take years of training. It doesn't take years to implement. It takes like weeks to implement, and then you just get going, and you can pick an area to start. I mean, we started within deciding we're going to do this, and it was weeks to get it up and going, to get this portion started, right? So there are audit modules, there's document control modules, there's additional features, risk management, but you got to pick what makes sense. If you've already had an audit and you have 100 pages from ACA that are already written up of here are all the issues we found, you may choose to start with, I'm going to load those issues as if they were incidents, and then just start with your corrective action plans. What am I going to do? You don't necessarily need to go out and find additional problems if you already had a 100-page document received from the state that here are issues I have, right? I've had that happen to people I've talked to. You figure out what makes sense, but you really can use the tool to help you understand where your biggest issues are and help you manage to fix it. So if you're in a position where you've got, had a recent audit and you have a lot of issues identified, this can help you then to improve, whether it's a leapfrog score from a hospital or CMS score or your ACA audit for licensing or complaint or whatever. Help you manage to get it done and document that you did it. And then sharing that in the system makes it very visible. It gives you a bird's eye view. Wherever you sit in the organization, you can see, here are all the issues we've had. Here's what we did about it. And here's what's still outstanding to do about that specific issue, right? Because at any point in time, all you need to do is go in the system. You don't need to get spreadsheets from the different locations or facilities. You can just go in and look at where they're at, and then you can ask the question, knowing already, here's where we're at. Well, why are we not on track, or do we need to change our deadlines here due to what reason, and so forth. So it helps us manage things, whatever level. If you're at the facility or you're at a corporate level, it's a tool for you to be able to manage it in a very user-friendly way and quick to get up and going. It doesn't take you years to get up and going, like some of the large GRC systems that I've implemented before take, several years to get up and really running.
So Monica, I have a question. With your growth plans, do you feel that using a automated system like Aperitisoft Healthcare and having the confidence that it is delivering a higher level of care to your residents and giving you more command and control over what's happening on the floor, does this accelerate in your mind your growth plans and things that you might want to do with your facility?
Yes, it makes it much more palatable to feel like you're going to still have control. You add another facility, as you look at potentially franchising and so forth that I'm looking at, it gives you the ability to have a bird's eye view, as I said, to see what's going on, even if you're not there.
Right.
Because you can't be everywhere. I mean, if you're managing different locations, it gives you line of sight into what's going on without physically being there.
That's powerful. That's powerful.
That's huge.
Mm-hmm. I mean, that's the thing. If you're sitting at a corporate location as a CEO for a large chain of long-term care facilities in a number of different states, you're not going to, be at each site, but you can compare. It also allows, from a very efficient standpoint, different locations to share their issues. So if you have an issue at one location, likelihood you have the same issue at another location is pretty high. So you don't need to recreate the wheel. You can think about what are good processes and procedures to put in place to address, say it's falls, right? Addition the issue with restraints. If this is what has worked at one place, you can have further discussion and agree, is this a change to the overall corporate process and procedure, and then you implement it, you change or update your corporate process and procedure and make sure it's rolled out and everybody's doing it. It gives you a way to roll it out to a number of different locations, and to share findings and corrective action plans.
I lit up because I'm like, okay, so what I'm hearing you say is literally it allows you to be proactive in healthcare. Is that what I'm hearing?
Yeah, that's why you got that big smile.
Yeah. Well, we've literally been talking about this all year long. We want proactive approach to care versus that reactive, because healthcare is so reactive at the end of the day. And what I heard a leader in a long-term care facility literally just say was, we have the ability to now be proactive with our care. I mean,
yeah,
so I joke with the residents sometimes, and I tell them, I say, Ingrid, you're not falling on my watch here, Ingrid. All right, it's not allowed. Okay.
I'm excited. That just made me smile.
Instead of before, okay, you catch them, they fell, they're on the floor, you're sending them to the hospital. Now I'm like, no, Ingrid, you're not allowed to fall.
Exactly.
End of story.
We're going to ensure that is so wild.
I love
not 100%. Nothing's 100%, right? But we can take care of maybe 99% of it. Every once in a while, I'll have a Houdini resident who will go to the end of the bed, and they'll figure out how to get in between bed rails, and they'll figure out I'm going to get up and whatever. But
the elderly are amazing that way.
They are.
But I'm like, how did they do that?
Yeah.
But it takes care of probably 99% of it, and then you'll still have an alert earlier that if the person did start moving and did eventually actually get up, you'll still get there a lot earlier. If you didn't have these alarms, they could be, I've heard of facilities having issues where they found the person 10, 12 hours later after they've been laying on the floor.
Oh, that's awesome.
That actually happened.
I've run into that too. I've run into that as well, and it's
unfortunate.
As a nurse,
and then what happened at that location, it's a location close to ours, in Sarasota, Florida. And questions come out. Your legal risk goes up, because if the person was laying on the floor for 10 or 12 hours with a brain bleed or whatever it is, broken hip, it's a different story than if you found them 1 minute after they fell, right? Let alone if you can prevent them from falling at all. But with those alarms, they will go off. You may not always catch somebody, but at least you'll have an alert that they got out of bed and they are on the floor.
You were going to say something, Rob?
I was just going to say, as a nurse, there's, and I'll acknowledge, I've not been bedside in an extraordinarily long time, but knowing the state of healthcare, knowing how challenging it is across the board with terrible staffing, retention and burnout being extraordinarily high, risks being through the roof. There's because of not training people appropriately and not having systems in place to support where there's our education system has failed us because we're pushing people through too quickly. These are all things that we acknowledge statistically across the board are happening in healthcare right now. And if I was to go back to bedside and I was at a hospital or a facility of any kind, and I found out that they were letting patients sit for 10 or 12 hours having fallen, and there's too many other job opportunities for me. I'm going to quit immediately. That's too high of liability. You guys are not taking care of patients, and I am gone. There are facilities like yours to give us a little bit of hope, right? If other people can start doing what you're doing, if other people can start adopting, there's systems and cultures of quality, right? There's every podcast we've talked about so far this year, you have addressed. There's right, quality has a seat at the table. You as the leader are thinking about quality, risk, and compliance with your strategic plan. There's right, you just talked about how it aligned with your ability to even franchise if you wanted to. There's you talked about being proactive versus reactive. There's right, I could go and just lay out all of our prior podcasts and say, this is an organization that's actually doing the right things for the right reasons and seeing growth, right? You're seeing a 76% improvement or 77% improvement, 150% improvement in identification. These are wonderful things. And if I was going to be bedside, it would only be in organizations like yours.
Monica, I have another question for you. It's another strategic question, but it may be a little bit out of your comfort zone. Looking out at hospitals now, there are hospitals out there that are on Leapfrog scores that they're constantly in the CD and even failure area. They're struggling to score well on DNS. What would be your advice on how to use a system like Aperitisoft Healthcare to get them out of the doghouse, so to speak?
So I would go back to the survey or the audit that was done, whether it's Leapfrog or ACA audit or whatever it was, CMS, and I would go through and I would look at what are the issues that were identified, systematically go through them, right? If there's 100 pages of issues, whatever it is, group them. Maybe you can group, figure out how do you group these issues if you can, right? Under headings, whether it's related to medication, it's related to infection control, skin integrity, whatever it is. Go through and figure out what were the biggest issues that contributed to my lower rating. Okay, I'm going to force you to prioritize because you only have so many resources, right? So many hours. I would force us to prioritize.
I'm assuming that you can. I know you can, but you can create incidents around these things that they were flagged.
Right. So you would load them in as incidents based on the report that you received. Okay. So I would start out and attack it that way. Then you're gonna score them as far as, if you load them in, they'll get a scoring so that you can see which ones are your most severe categories.
Prioritize, yep.
All right. So the first thing you're going to do is the system is going to, with loading them in there, it's going to do a force ranking prioritization of where your biggest risks are. What do you need to do in order to move the needle, right? You're going to need to attack your biggest issues. And then I would assign leads for maybe one overall lead for each of the main categories. Who's going to be the lead? And that person can then decide how they're going to manage their area to improve. If you're a hospital chain or you're a single independent hospital, you're going to have to decide who's going to be the lead. It could be you could have different facilities take the lead on different things because different facilities or different hospitals in your whole network may have a bigger issue with certain areas. So I would pick a lead from a hospital that this was a significant issue for that hospital if I'm trying to overall improve for my whole hospital network. But make sure that you have somebody accountable to drive those improvements in each of those areas with a support network, right? Then they can decide who can help them out with driving milestones, brainstorming and driving milestones to improve overall, and then tracking it, right? If you don't track it, what gets tracked gets done, right? And if you hold people accountable to making these improvements and it's tied to their performance review or however you do it, these things need to be key objectives for those individuals in their comp planning and performance HR objective plans for the year or semi-annual, or however you do it. Then that makes it a big deal for them, instead of it's just an afterthought. Often risk quality are afterthoughts, but it really makes a huge difference. If you have high quality, high performance organization, it's going to make a lot of things better. Reduce your legal risk. It'll also improve your revenue, because you're going to have a lot more likelihood of getting new clients, particularly in long-term care or the hospitals. If people have a choice of which hospital to go to, they're much likely going to choose an A-rated hospital, or one with a good score versus one that isn't, right?
Patients actively dying in the back of an ambulance pull up their phone in a designated service area and say, "Please don't take me here. Please take me there." That happens.
That is so true.
All the time. There's people know they have a right to choose now, and they do. They exercise that right, and they will Google that. Be like, "Am I going to die in the waiting room, or am I going to survive the stay?"
And what Monica said is interesting, guys, because it's implied in her statement, but it's implied that the CEO of the hospital is behind this, right, and supporting this, and is going to give the resources and the support needed for these designated leads to get the job done, and is expecting the system to be reporting back to the CEO to let them know progress is being made. And that's very powerful. That's very powerful. There is a question from the users, guys. We're into that period now. Are there any requirements to include in the corrective action plans, Monica? Are there any specific requirements that are included in the corrective action plans?
Well, you need to understand a bit about the detail of what happened, right? The root cause. Try to understand the root cause. It's a bit like when I think of it, from a Six Sigma standpoint, right? You try to think of the root cause of what happened and so forth, if you can, because that's the only way you're going to ensure that the suggested action plans are actually going to make a difference.
Well, I think a good way to answer this too, maybe I can help as a system expert here, is that the software automatically connected that corrective action plan back to the incident, and specifically to the how you scored that incident and where the weaknesses were, so that when you're putting together this corrective action plan, you're addressing in the system those weaknesses, directly reflecting those weaknesses. So when they get done, you're actually reversing the negative score to a positive score in those areas, so you can see the needle move, right, from a weaker quality score on that incident to a growing quality score on that incident as you're making the corrections in the system. Is there anything else you guys would want to add to that?
Yeah, so the biggest thing that I want to add is having a system like ours. There's a system that captures really good data for any type of CAPA. Includes all of those things. There's a really clear scope. There's who's doing what, when, where, why, and how in the measure, monitor, maintain process. But what's most exciting, and what Monica is doing, with the system, is able to capture, the cost of quality. Right? Being able to truly speak to your strategic plan, and how you can align by how much revenue you're able to retain. By able to reduce your waste. Over time, whether that be operational or total loss from, there's many different types of scenarios. Every element, your corrective action should be quantified. Into the cost, whether that be a direct cost, an FTE cost. There's costs of quality that are really hard to identify when you're doing it on pen and paper, because I used to do it in a marble composition book. And so I know how hard it is to do, and I also know that the CFOs or investors would laugh at the data of where, right? So like, where did you get this? Well, it came from my book. This sits on my bookshelf. It feels like it has low integrity. So when you have a clear picture of your cost of poor quality, it really helps you align there's your strategic plan, there's your cost of doing business, where you can invest in your resources, right? And I think that that is a wonderful tool for executives like you, Monica, to be able to say, I'm going to hire somebody for this. Or I can franchise now. There's because I have streamlined my processes so well. I am very lean and I'm very smart in what I am doing. My patients are safe. I have best practices in place. There's
and it's repeatable.
It's repeatable. Yeah.
It's repeatable. Yeah.
And we had another question where are the specific steps in any order necessary? There's
about milestones, I guess, is what this is asking about.
Maybe. So you get to assign all of your action items. There's with specific due dates, with certain accountabilities, right? So like we kind of created it with essentially the RACI model in mind, right? Who's ultimately accountable? You assign the CAPA owner, and then you have milestone owners. There's who are responsible to actually complete the tasks, right? You can put in informed, right? So there, those steps are in place. But the other steps are built in the flow of what healthcare quality best practice standards are. So using NAHQ, ASQ, there's as our industry baseline for best practice, and ISO 9001, there's how does quality look, right? We built the program so that it starts with identifying root cause after your primary assessment, moving into CAPA management further down into milestones, right, into cost. And then implementation. It is built with those concepts in mind. I hope that answers your question, LinkedIn user. And Monica, do you find that to be true in your use of electronic quality systems now? How that has changed your ability to manage CAPAs?
Yeah, it's you're able to just handle a large number of them at any point in time and just be able to know where you're at, I think and really push getting things done.
Are there any other questions out there, guys, that you can see from the audience?
Not in the audience chat. We do have a couple from the private chat. If you had Monica, if you had a magic wand and could fix one systemic issue, across all of healthcare, what would you fix?
Is that from the audience?
Huh? No, that's from our private chat. So that was somebody internal that's asking that.
Okay.
I guess it becomes just embracing that, having a mindset of quality.
Yes.
At a hospital or a long-term care facility, having that mindset in everything you do will just shine through, because it's just in everything, whether it's your communications with families, your communications with the residents or patients, your communications with staff. It just is a prevailing theme that if you embrace that from the top down, it makes a huge difference in how your organization can run, and a lot less stress, and a lot happier, and a facility or a workplace with a lot better morale and a reputation in the community.
I love that answer.
Hey, Monica, I know you'll probably try to give me a long answer, but I'm going to ask you to give me a short answer. Okay. What percentage return on investment you think you have after now making the decision to go with a system of Aperitisoft Healthcare?
Well,
100%,
it's
200%.
Yeah, it's way over. It's not even. I mean, as far as.
Where do you think the big financial
more.
contributors would come from in terms of that calculation? Is it in revenue, cost reduction? How would you articulate that?
I would say it's in revenue. It's all of them. And that's where it's not one or the other. It's all of them combined. It's the improvement in revenue, ease to get clients with the reputation, and explaining to people what you're offering makes it a lot easier to get clients in the door. From a cost standpoint, it reduces a lot of crises. It reduces staff turnover. Legal risks are way down. So it's not one category. It just is profound. It's covering almost everything you do. If you have a quality mindset in how you operate and a compliance mindset of how we're going to handle things, it just prevails in everything you do, every area.
Awesome.
I don't think we can add anything to that, guys.
No, that was like a last word and everything. All at once.
Yeah, that was pretty good. We are out of time. We've reached our 45 minutes. I want to thank the audience for participating today. We always appreciate you. We can't do this without you being out there listening and participating. It's greatly appreciated. I want to thank Monica for taking time out of her schedule to be on our show today. We're going to ask you to hang around, Monica, for the after show. We do an after show, everybody. If you want to find that, you can find it on YouTube. We delve in a little bit more and say things that maybe we wouldn't want to say in mixed company. So
it gets spicy.
Yeah, it's really spicy. Our next show will be in December. And do we have a date for that, Rob?
There it is. I think the third week. Let me pull it up on the calendar right now. We can give the audience a real answer.
Before Christmas, right? Right. Before.
And it looks like it is the 18th.
18th of December. We're going to do a recap of the year, kind of look at the whole year and talk about different topics and the hot points that came up throughout the course of the year. We're going to revisiting those in December. So again, thank you for joining us this afternoon, and we'll see you next month. Bye all.
Bye.